One last attempt is, can anyone on the call hear me, on the virtual call?
This is Alicia Conde. How can I hear you?
All right, excellent, thank you. I'm not sure exactly what the technical difficulty was, but we seem to have ironed it out. I do apologize. So, Ms. Hackett, you are on the call. Megan Healy, Chief Workforce Development Advisor, are you on the call?
Yes, I'm here.
Yes, I'm here.
Judy Jackson, Department for the Blind and Vision Impaired. Karen Brim, Department for the Deaf and Hard of Hearing. Joni Latimer, Department of Aging and Rehabilitative Services.
Yes, I'm here.
Gail Thompson, Department of Aging and Rehabilitative Services. Joel Brana, Department of Agriculture and Consumer Services. Catherine Paxton, Department of Agriculture and Consumer Services.
I'm here.
Charlotte Riddell, Board of Nursing, Department of Health Professions. Elizabeth Carter, Healthcare Workforce Data Center, Department of Health Professions.
Yes, I'm here.
Corey Tillman Wolf, Board of Long-Term Care Administrators, Department of Health Professions.
I'm here.
Kurt Elward, Department of Medical Assistance Services. Barbara Seymour, Department of Medical Assistance Services. Randall Stamper, Virginia Community College System. Todd Barnes, Department of Veterans Services. Heather Laguerre, Department of Veterans Services. Sam Kukich, Dignity for the Aged.
Present.
Bob Kukich, Dignity for the Aged.
I'm here.
Erin Hines, Dignity for the Aged.
I'm here.
Susan Hines, Dignity for the Aged.
I'm here.
Jen A. Kiggins, Senator, General Assembly.
I'm here.
All right. Yes. Hello, is that Dana Parsons? We're not there we're not there yet. Senator Kiggins, we saw that your legislative director has called in. Do we need to elevate him so he has speaking privileges as well? To mute and unmute himself, I should say.
I don't think so, but I'll double check with him, and if he should be okay just listening. Thank you, though.
All right, thank you. Christina Holloway, Beach Health and Wellness.
I'm here. I'm here.
Dana Parsons, Leading Age Virginia.
I'm here.
Alicia Cundiff, Leading Age Virginia.
Here.
April Payne, Virginia Healthcare Association, Virginia Center for Assisted Living.
Damn it.
Scott Johnson.
Present.
Thank you. Vivian McDaniel, Virginia Nurses Association. All right. Dr. McDaniel,
Yes. Can you hear me?
we can. I just wanted to let you know, because you're a call-in, we're not able to elevate you to panelist so that you can control the mute, or that we can control your mute and unmute. So you will have to make sure that you mute your own line
Okay,
if you're not speaking, okay?
I will. Thank you.
Thank you. And then Rebecca. Joe Hilbert, Office of Governmental and Regulatory Affairs, Department of Health. Heather Anderson, Office of Health Equity, Department of Health.
I'm here.
A. Carol Pratt, Office of Governmental and Regulatory Affairs, Department of Health.
Here.
And I am here as well. All right.
This is
The
Barbara
agenda is
Seymour.
now
Can you
displayed
hear me
on the
now?
screen. We are going to start with a public comment period, followed by a review of the... I'm sorry?
Barbara Seymour, I
Can
was
you say
just
that
checking
again,
in.
whoever
Can
was
you hear
talking?
me? Barbara Seymour?
Yes, Ms. Seymour.
Just seeing if you can
Did you
hear
have a
me.
question?
I wasn't able to be heard before when you called the roll call, so I wanted to acknowledge I was here.
All right, excellent. Thank you, Ms. Seymour. As I was saying, the agenda is displayed on screen. We're going to start with the public comment period, followed by a review of the work group roadmap and revisions to it that we had discussed last time. And then we will go into initial discussions regarding curriculum and educational debt, followed by discussions of our next steps and any other business before the work group. So, on the subject of the public comments, we did receive several written comments in advance of the work group's meeting today. If the comments were received 24 hours in advance, which would have been 1 p.m. yesterday, Sunday, they were sent out to the work group members. They were sent both on Friday and on Sunday. They are also, all of those comments are available for not only work group members, but members of the public to review. They're out on OLC's website. It's under the Chapter 932 section in the meetings subsection. And as a reminder to everyone, a summary of the written comments that we received throughout the course of this work group will be included in the final report that we transmit to the General Assembly. And if anyone has written comments, we do ask that you send them to Dr. Pratt and myself. I will note that there were some additional comments that came in after 1 p.m. yesterday. We will bundle those together and send them out to you in advance of the work group meeting that follows this one. The reason we ask for that 24 hours is so that we have the time to put it all together, get it posted, get it sent out to you all. So you will receive them, just not in advance of the meeting that we're having right now. Yep.
We're now at the public comment period on today's agenda, and I'd like to review how this will work. When registering for this meeting, there was the opportunity to sign up to speak on a topic. The list of persons who signed up to speak was finalized at 11:45 this morning. Pursuant to the Board of Health's public participation policy, each speaker will have a maximum of 2 minutes in which to speak. There will be a countdown timer on the screen, and a bell will ring when the time has elapsed. If the bell rings while a person is speaking, we will allow the speaker to finish that sentence, and then the speaker will be muted and the name of the next speaker will be called. You'll be unmuted by the host when it's your turn to speak. In addition, all speakers are reminded that this is an opportunity for you to address the board on any topic of your choosing. However, it will not be a question and answer period, and there will not be dialogue back and forth between speakers and work group members. Ms. Allen.
All right, thank you. There are 4 persons who signed up to speak today. I will be calling 2 names at a time. The first person that I call is the name of the person who will speak first, and the second person is the person on deck to speak next. That first person is Kathy Schroeder, and the person who will speak after her is Patricia Vanucci. If you'll give me 1 moment, and I will get the timer up on the screen for you. Well, All right. So you should see the timer on your screen right now. And Ms. Danson, if you will unmute Ms. Schroeder. Ms. Schroeder, are you there? Ms. Schroeder, are you there? Ms. Schroeder, we're going to remute your line and we will circle back to you. Ms. Patricia Venucci, are you there?
Hello.
Hello, is this Ms. Venucci?
Yes, ma'am.
All right, I'm starting the timer now, okay?
Sure. My mom has been in a nursing facility, long-term care, for a little over 2 years. Since the COVID has started, we are not allowed any window visits. As of Phase 3 opening in Virginia, the residents are still not allowed out of their rooms, this being the only nursing facility that we can determine on the entire peninsula that is not allowing that. My mother has lost 12 pounds since March 2nd. I have asked that I could stand at the window after I bring her food because I'm hearing that she does. I bring, but I've been denied the window visits. When I'm in the parking lot bringing her food, one of the cleaning ladies told me that she always cleans my mother's room in the afternoon because of all the food on the floor. I've also heard that now at times she needs to be fed. My mother has a ravenous appetite, has always eaten every drop on her plate. She's depressed. She wants me to come and take her out. She is 101 years old and I'm not able to take care of her by myself at this point because they have now gone to using a Hoyer lift on her. She was standing and transferring before COVID started. They're extremely short-staffed. I'm very distressed over a number of things that have happened since COVID started, and I'm going to have to make it real quick, but she's fallen out of bed with an injury. She's had vaginosis from assumingly sitting in urine or feces or improper hygiene, and they've lost her wedding band and now the weight loss. So those are just tip of the iceberg. The staffing is extremely short there. They're advertising for 13 positions in a 60-bed facility right now. I'm concerned about the money from the government and where it's gone. The extra $20 that everyone was supposed to be getting does not appear to be going to staffing. That's my comments. Thank you so much for listening.
All right, thank you, Ms. Finucci. Ms. Schroeder, are you on the line? And while we wait to see if Ms. Schroeder is on the line, excuse me, Eleanor Druniak is on deck. She's still having trouble? Okay. Ms. Schroeder, your line is unmuted. We'll go to Ms. Druniak. All right, Ms. Druniak, are you on the line? Oh, 1 second. All right, Ms. Druniak, you are unmuted.
Okay, you can hear me now?
Yes, we can. Your time begins now.
Okay. My mother and father have been in a nursing home in Virginia Beach for 2 years. We lost my father in December. My opinion, neglect. My mother is still there. Since COVID, she has lost 16.5 pounds. She now weighs 89 pounds. I can go to the window. They did tell me that I can try to bring something for her to eat. The only thing she tells me when hospice FaceTimes with me is, help me, help me, help me, please help me. She never has on clothes that we've bought for her. I keep buying a gown for her and it's gone. We don't know what is happening and we don't want to lose another parent. There are not enough staff. She can't eat. They don't want to feed her. They say she can feed herself. If this is giving you any indication of what is happening in the nursing homes, there are very few that still have the energy to care about these patients, but they're wearing thin, and we need help. They need help desperately. We need to know just that a parent has dignity a little bit before you die. We don't know where else to turn. So it's happening everywhere. You heard before me. Hopefully something can happen. I thank you for letting me talk. I don't want to try to get emotional about this. It just gets hard to watch a family member deteriorate every day and no one there to care for them. Thank you for listening.
All right, thank you for your comments. I believe we have advised Ms. Schroeder, she's in communication with us telling us that she can't hear, so we've asked her to connect and to disconnect and to reconnect to the call.
And I think she may have done it, and I unmuted her.
Okay. Ms. Schroeder, you are unmuted right now. Can you hear or speak at all? Okay. Ms. Kukich, since you have Ms. Schroeder and you're in contact with her right now.
I just asked her if she could hear, and I didn't get a response yet.
Okay. Would it be possible for you to call her and then put it on speakerphone and hold it up to your mic? Sure. All right. And while we do that, Ms. Deborah Buchanan, you are on deck for the next public comment period, all right? Or for the next slot in the public comment period.
Are you talking to her Buchanan now?
Not yet. We haven't unmuted her line.
She said I can call her. Is that what you want me to do?
Ms. Schroeder, yes.
Hey, Kathy, I think since we can't connect on the computer, what we're going to do is I'm going to put you on speaker and put you to the microphone. Is that all right? And you'll be speaking and making a comment. They're going to give you 2 minutes. Okay? So switch up there.
So if you will put her on speaker.
And there you go. I'm here.
All right. You can begin now.
Hey everyone, I'm Kathy Schroeder, and I have been active in the dire situation that we have with respect to nursing homes and assisted living facilities. And I'm really enthusiastic about what outcomes we can and impact we can make with this work group. We have a serious issue in Virginia. It's being ranked 36 in the state in terms of poor care. It seems that a lot of the state inspection people from the human services inspect all these facilities nonstop for years and years and years. There's no enforcement of penalties. Elder people are dying. There's insufficient staff. The CNAs are not properly screened. They're not properly trained. They're paid low money, no benefits. This is a problem. These are the first line people touching our family members' bodies and giving them aid and comfort. Furthermore, there seems to be an ongoing trend of these facility operators not to do their job. They don't have operational procedures in place. I'm going to start talking fast. The licensure regulators seem to be lax in what they're doing. I'm just speaking from my experience. The Attorney General's office, when cases are reported to them for investigation for abuse, the first thing they tell you is you will never hear from me again. Why the heck not? There's a shuffling and a hiding of all of the evil that we experience out here in the public land. We are fed up with this. It will become public. We will make sure that it becomes public. We will be sure that it becomes a Virginia state issue and that the issues must be addressed, the problems, and we will be sure that it becomes a national issue. Trust me, it will happen. Virginia has a lot. It's not about just educating people.
Ms. Schroeder.
All of it, we're done. Okay, thank you.
All right. Thank you.
Thank you.
All right, and our final commentor is Deborah Buchanan.
Hello?
Oh, hello.
I'm sorry, can you hear me?
We can. There's a slight audio reverb.
Okay, let's see if this is better.
It's not ideal, but it's only 2 minutes, so
Okay.
we'll go for it, all right?
Let me just say that I want to echo everything that the previous person said, that this is not an independent nursing home or one single or one state. It's happening across the country. I mentioned 3 things to you. The question is, our mandated reporters are not making their report, and we do have a question of staffing across the country. The ratios are not there. Everybody can go in and look at the Center of Medicare Medicaid Services, where their surveys are, and everybody is short on the ratio. The other thing is, in 1987, we had landmark legislation passed, which was called OBRA 87. All of these regulations are repeated in the Residents' Rights Book, and they're being openly ignored. The right of dignity, that their activities of daily living are to be guarded. They are to be able to participate in a residential council, or a family member is able to do that. They are to be free of all restraints. They're not to be given antipsychotics or benzos. This is happening to all of them. It is forcing our elders to die early, prematurely, and there is frustration. This is not regional, as I told you. This is happening across the country. So sorry for the echo.
No, that's all right. Thank you for your comments. All right. Okay, this concludes the list of individuals who signed up to speak, and the public comment period, today's work group meeting is now closed. So if you'll give me 1 moment, I will stop the sharing of the timer, and I will turn it back to the sharing of the PowerPoint presentation. Oh, this is what you're seeing on the screen. On your screen. Okay, excellent. All right. So as we had previously gone over in the agenda, we are going to touch on the revised work group roadmap. As you may recall, at our last meeting, this is what had been presented to the work group members: the educational pipeline with the sub-bits underneath there, educational debt, healthcare financing, recruitment, and retention. And as a result of the last meeting that we had, this has been refined, has been added to. So just as a refresher, We still have education on there. We have the pipeline, middle schools and high schools, college and university, continuing education, and we made sure that continuing education includes leadership training for those who are in the clinical workforce. Also, in the education pipeline, those who are doing career changes and transition. So that's going to include folks who, for example, are coming out of the military and are transitioning to civilian careers. There's also a conversation about including curriculum, not only in the avenue of special needs of resident populations, making sure that there's curriculum addressing that, but also curriculum about the special needs of student population, because there are folks out there in the workforce today and potential individuals who could join the workforce who do have special needs, such as the deaf and hard of hearing, the blind and vision impaired, and we need to make sure that the curriculum that's out there is addressing their needs as well, and letting them know that there are opportunities in the clinical workforce in nursing homes for them as well. Student debt was still going to be included as a discussion on that. On healthcare financing, we had expanded a little bit more to kind of flesh out what that means. That means including discussions about the payer mix that facilities have presently and ways to address that, the reimbursement rates that facilities are receiving for their residents. And then financial incentive programs, which can cover not only specifically staffing, which is one of the things that got this bill started, but also quality of care programs out there as well. And then on recruitment and retention, we expanded that quite a lot to talk about salary and wages, other employment benefits, which would be your non-salary and wage information. That's going to be like your health insurance and the like. Staffing ratios, advancement opportunities, both within the facility and outside the facility, and of course leadership opportunities, again, within the facility and outside the facility, which ties back to the educational component we had 2 slides back. And as was the case with the roadmap that we talked about at the last work group meeting and the one here, all of these pieces are very interconnected. It's difficult to talk about one of these things in isolation because so much of it is intertwined. So it's hard to talk about the hiring, for example, of and the retaining of staff if you don't actually have the people there who are trained in order to hire. So you need to make sure that they are there, educated, and willing to be hired. So that is the revised roadmap based on the discussions that we had at the prior meeting. And as you may recall at the prior meeting, we had discussed education pretty broadly. And one of the things that we had talked about as part of that educational component, Leading Age Virginia was kind enough to share with us some of the initiatives that other leading ages around the United States had begun in order to get middle school and high school students interested and involved in the nursing home industry at the middle school and high school levels. And one of the things that was discussed was, as part of that conversation about getting the younger, under 18 crowd in there and involved, was service learning, volunteer opportunities, community service. So as part of that service learning component, which we really feel kind of ties into the curriculum aspect of it, Dr. Pratt went back and did some additional work, some research behind the scenes, worked with the Department of Education here in Virginia. And so when it comes to, we wanted to update the work group members about service learning here in the Commonwealth as it presently stands. So the first bullet point here is the statutory authority for the Department of Education to establish the requirements, the minimum requirements that the Board of Education has to include in its graduation requirements. It's a pretty lengthy list, which is why I didn't reproduce the whole thing here on the screen for you. And as lengthy as that particular statutory requirement is, the regulations go into even more detail. So the regulation that talks about graduation requirements 8 VAC 20, 131, 51. This is for your ninth grade, the folks who are entering ninth grade in the 2018-2019 school year and forward. There are education requirements for folks who entered ninth grade before that point, but for the purpose of the discussion, this is probably the cohort of kids that we'd be looking at. Presently, CTE courses, career and technical education courses, are required if a student has not gotten advanced placement, international baccalaureate, or honors courses, if they haven't gotten credit for that. But as you can imagine, career and technical education is pretty wide-ranging in terms of what satisfies those requirements. So a kid could take a computer science course, for example, and they've checked off that particular requirement for graduation. So when it comes to service learning, so that right now, under Virginia's graduation requirements, doesn't necessarily translate directly to credits for graduation. If you look at the regulatory requirements for graduation in 8 VAC 20, 131, 51, their local school divisions, they have the opportunity to add some additional requirements, electives, provided that the Department of Education, the Board of Education approves them. And in Dr. Pratt's discussions with the Department of Education, they did say that there may be an opportunity to work with individual divisions, by which they mean local school boards and things like that, on local electives if there's a regionally targeted need. But right now, it's pretty, there's not a specific avenue by which service learning itself, just the service learning component, can be directly translated to credits for graduation. So that is something that, if the work group is interested, that could be a recommendation of the work group to make that an avenue. And then there are some things that are out there right now, and I'm actually going to hand it off to Dr. Pratt because she is the one who pulled this information together about Fairfax County, about what they're doing.
Fairfax County does have a program that's been in place for several years. They require 5 hours of community service or service learning, and those two terms are used interchangeably for grade 6. Then in grade 8, that moves up to 15 hours, and then in grades 9 through 12, students complete 10 service hours per year for a total of 40 hours. This can be in a wide variety of opportunities, and they are not targeted to health careers, but it sounds like a program that's already in place that we might use as a model in the state of Virginia. Thank you.
This is Sam Kukich. Could I interject something? I understand service learning, and I think there's a great benefit to it. In some ways, I think high school kids and middle school kids are overwhelmed with a ton of activities in this day and age. I wonder how they get their homework done. But here's the deal. If we don't have any incentives for the current people in this workforce, how in the world can we expect these young kids to look forward to continuing in this line of work if they know the pay is bad, and they're going to figure that out right away when they're working alongside others in these facilities? As the people who made the public comments before, it's very, very obvious. So I don't know what incentive you're going to give the kids that you're not giving the people who are actually in the field.
Thank you for, thank you for raising those points. When it comes to the incentive for students, I mean, the immediate incentive in a service learning environment such as this is it's a credit towards graduation. In terms of the career incentive, the potential financial incentives for it, I think that would be outside of the scope of a service learning recommendation, but I think that is a component that needs to be addressed as part of the increasing of the availability of clinical workforce. So I think
in conjunction with that, though, if we're here to help the elderly, when is that going to happen? Because what we're talking about now is, okay, so now we're going to approach the middle school. What do we do with some of the speakers who are worried sick about their loved ones right now in the nursing homes? What are we going to do for them?
When it comes to the care of those who are in the nursing homes right now, the mandate of this work group is to make recommendations about increasing the availability of the workforce. And that's what the work group needs to have their focus on. And through the recommendations that we come up with, you know, if they are ultimately adopted by the General Assembly as policy proposals, they can have impacts on the quality of care that is being given to those residents in the nursing homes. But
if we continue to look at the forecast of the workforce in the future, and we're not looking at what's wrong with the whole system right now, we're missing a big element of that. Because there's a lot wrong with it right now.
Right, and so in terms of what's wrong with it right now, I think that can be a part of the conversation, but the conversation ultimately needs to be driven at increasing the availability of the workforce, because that's the explicit mandate of what we've been given to try and figure out.
But the issue too is the workforce is going to work for places that are easier for the same amount of pay. You know, they'd rather go work for Chick-fil-A. Their environment's nice, they get better pay, they're treated well, they're not stressed out. So those things need to be dealt with. You just can't say, well, we're going to prepare this workforce when, in fact, the workforce now is drained. I mean, they're exhausted. Ask Erin, what do you have to contribute to this? Because she is a CNA.
If I talk about, can I talk about retention for a moment?
So my preference would be that since we do have this roadmap that we're working our way, and it seems, I mean, it's set up in such a way as to flow from one to the next. So we start at the education, which is where we get folks into the pipeline of the workforce. And then as we move them through the pipeline, then we get to the recruitment of them and the retention of them. So that is why we've been working our way through the roadmap and starting at the beginning of the pipeline as opposed to the end of it. When it comes to the salary, the benefits, the wages, all the financial and non-financial incentives for being part of the workforce that is in nursing homes, that is going to be part of the discussion. It's included on the roadmap for that reason, because you're right, there are folks who are already out there who are working at these facilities who are being tempted to work at in your example, at the Chick-fil-A, or to make a transition, and maybe I don't want to work at a nursing home anymore, I want to work at a hospital, or I want to go work for a home care organization or a hospice, things like that. So I understand that there is that financial pressure to want to seek work elsewhere. There is the the non-financial stressors that can drive people to want to change the job that they're in, whether it's the work environment because there's no advancement opportunity where they're at, or there's no, just the general work environment itself is toxic, irrespective of whether there's advancement opportunities. Those are all things that need to be addressed. But my preference would be that because of the way a person works their way through the workforce, they got to get into the pipeline first, which is what we're trying to talk about with the education component of it. It would therefore follow afterwards. Now that we have them, they're educated, they're ready to go, how do we make them put in their application and want to stay with a nursing home versus going to a hospital, or saying that they don't want to be in the clinical workforce at all anymore. They want to jump jobs and go get an MBA or something like that. So I do absolutely want to hear your comments and any feedback that you have or that anyone on this work group has about the retention and the financial aspect of it, and trying to keep the workforce that we have presently engaged and wanting to provide care, quality care, in the nursing homes. But I would like to keep the discussion on education today and reserve that for a future discussion.
Please excuse me for continuing on this vein, but when I hear that you're talking about educating, and I look over here and I see a college-educated CNA who's getting paid $11 an hour, and tell her why she should stay. Let's deal with the here and now instead of a theory for the future, because that's what's happening.
Can I ask a question about the educational pipeline? Do we have any data as far as Maryland and Washington, D.C., how many of those students who are required to do service, what do they call it, service learning, how many, I wonder what percentage of those are actually going into the field that we're discussing? It might be helpful to find out if it's being effective.
I don't have those numbers for each day, but we will be more than happy to reach out and get those numbers for you. My hope would be that Maryland or DC or both do track that. I don't know how granular the data might be. It may not be specific to nursing homes. It may just be like the healthcare umbrella, but we will do our best to get that information for you.
Hi, this is Todd Barnes from the work group. Can you hear me?
Yes, we can hear you.
So I'd just like to give a little input. Before I came into, I'm with the Veterans Administration here, and before I came into this career, I was in education at the high school level as a teacher and an administrator in Martinsville, Virginia, and I actually developed a service learning program for 2 years, and I certainly understand some of the concerns that are being said, but just to let you guys know what I found is we would have students after students, and by the way, we required an entire semester as a graduation. They would come and, for instance, several people would say, I'd like to be a nurse, I'd like to be a nurse. And so I would place them in doctor's office, nursing homes, different places of that nature. And I can tell you, I can't give you numbers, but I would say that about 50% of those over the 2 years after getting that experience were 100% committed to one way or the other. They would either say, I absolutely do not want to do that because that takes a certain special type of person, irregardless of the pay. I just am not interested in do that. Or they came back and said, this is my passion, this is what I want to do, thank you for the opportunity. Maybe I start off as a CNA, but I want to work towards an LPN, and I want to work towards an RN. So, and there's so many different avenues they could take. I don't think that we should just dismiss this service learning because it gives them an opportunity to get in and see the field and start, as you said. And although, again, I don't have the numbers, my experience with those 2 years were there were several that went on that stayed in the field because they realized that's really what they wanted to do. There were others that completely dropped off, and then there were others that say they wanted to be in interior design, but I didn't have an internship available for them, but I had plenty of opportunities for them at local doctors' offices, at nursing homes, and so they went into that just because they didn't have another avenue, and they ended up going in there. So it may not be a great number, but it does help. It may not help tomorrow, but it does help as we're going forward. And so I just wanted to give that input.
All right, thank you for that. Okay. Does anyone else who's on the call want to speak to the service learning?
Hello.
Hello, yes, who's this?
This is Dr. McDaniel.
All right, go ahead, Dr. McDaniel. We can hear you fine.
Great. I just wanted to say that I think it's a great idea. However, I do have a bit of a concern because I trained nurse aides in the state of Virginia and also worked on a task force that helped to enhance the nurse aid education program for the Board of Nursing. And one of my concerns is also that if you take students into the environment and you take them into an environment that is toxic, that they will hear very negative comments from nurse aides and other healthcare providers that may influence them negatively. So I do think that is a great idea.
It's 2 o'clock.
But I am a little concerned about that. And
All right, thank you. Oh,
yeah.
I'm sorry. Go ahead, Dr.
Well, I was just going to say, I'm sorry, and I was just going to say I have heard it so many times when I have taken my students to facilities. That's all.
All right, thank you, Dr. McDaniel.
If I could speak, being a nurse aide here in Virginia, I definitely agree. There is a lot of negativity and toxic things you see and hear when you go into these as a student during clinicals, and it is very disheartening because you are there to want to help people.
And I do think the recommendations of the work group need to be a whole workforce solution, from getting them into the pipeline to getting them educated to getting them there and wanting to stay there. So on the service learning piece of it, like I said, there's basically 3.5 options because Tennessee and Florida have done this hybrid sort of setup. And this is the specifics of what DC and Maryland require. Like I said, I don't have the numbers on what specifically they're doing for service learning, but Dr. Pratt and I will work on getting that. And hopefully it is granular to the level of specifically where they're going, such as nursing homes. But so Maryland, 75 hours, District of Columbia, 100 hours, which is a little bit more than what Fairfax had in theirs, but it is, in the case of DC, I believe it is, my apologies, only at the high school level, whereas Maryland has them spread out through middle school and high school, which I believe you got your hours done in middle school, didn't you, Alex?
I did, yeah.
All right, and for Maryland, it's the option of the 75 or a locally designed program in student service that's been approved by the state superintendent. But the 75 is the most common way that they go about getting that student service learning requirement met.
I can't hear anything you're saying.
Oh, I'm sorry.
Are you just reading the screen?
No, I was saying in the case of Maryland, that they have the option of the locally designed program, but it's more common for them to just do the 75. Sorry, the mask is very muffling.
I just thought I'd let you know.
Yeah, that's all right. Okay. And there are other targeted programs. So moving away from the discussion of service learning, there are other programs in Virginia that are targeted at getting students involved either in specific fields, just as a general matter, or in specific fields and specific parts of Virginia. So I'm going to, again, throw this to Dr. Pratt because she is the one who is not only from Southwest Virginia, but is the one who pulled all this information together for us.
There's a program United Way of Southwest Virginia has a very strong youth pipeline program and employment program. It's called Ignite. And they currently have a targeted program at IT jobs through a grant funding of $1.3 million. And I asked them if it would be possible to use that template of a program to encourage people to go into nursing careers or other careers that might lead to jobs within the nursing home. And they said that would certainly be a possibility. It's a program that serves about 20% of the geography of Virginia. They serve all the counties from Pulaski all the way to Lee County in Virginia. So it's a large program, large numbers, and they do a great amount of data collection. I think we could take a look at the program that they're doing now that's funded for IT jobs to see how it works and to see if there's a possibility of using something like that as a pilot or as a template for our work. I'll go ahead and speak a little bit about the AHEC as well, if that's okay.
Yes, please do.
There are several AHECs across the state, area health education centers. The one in Southwest Virginia has very strong pipeline programs, largely through the osteopathic college there, Osteopathic College of Medicine in Blacksburg. Now these are being done virtually. In the past, they've been done physically with students present there on the medical school campus, but now they'll be done virtually. They have tours that they can do virtually of the medical school, and the science, technology, engineering, and medicine camps that they're doing virtually. They also serve dozens and dozens of students in many different educational jurisdictions. The Virginia Scholars Program is one that their medical students are enrolled in. I think the pipeline includes not only the designations that we've heard before, but also those people who are interested in gerontology writ large, whether they be social workers with a concentration in gerontology or physicians that choose to practice that sort of medicine. If we need further information about what their data shows, I'm sure that they will be happy to share that with us. They have not done a lot of data collection to date because the programs are relatively new, but I'm sure that they can get us any sort of granular answers that we would like to have.
Sorry, let me lean closer to this mic. Dr. Pratt, do you happen to know let me hop back one slide. So the United Way of Southwest Virginia, obviously they serve Southwest Virginia, so it makes sense that their program would be there in Southwest Virginia. For the one that is the Southwestern Virginia Rural AHEC Pipeline Program, is there anything that would prevent that from being expanded, to the best of your knowledge, outward to other parts of the state?
The service region of the AHECs is well defined, and the specialist on that definition is in the room with us today, Heather Anderson. She may want to talk more about that. Should the other AHECs choose to do something similar, they all have AHEC Scholars programs, but should they do something similar, that would be up to the management and the leadership of the AHECs as I understand it. Heather, you may want to comment further.
Thank you, Dr. Pratt. Yes, every AHEC in the state has a service area, and they partner with medical schools and other health professional schools, including community colleges and technical colleges, to get help students interested in health careers. They do lack funding, but it is a state and federal partnership that funds these opportunities, and they have been around in other states. AHECs have been around for nearly 40 years. And if Virginia does not have a model that is comprehensive enough for us to look at, there are other states that we could look to for models and examples.
Do you mind if I ask a follow-up question? A couple follow-up questions, actually.
Go ahead.
All right. For the funding, you mentioned it was a mix of state and federal. How exactly is that set up? I mean, some programs are set up where the feds match whatever the state puts in dollar for dollar. Sometimes it's not that set up. It's something completely different. So how is the funding mix, or the share, I should say?
The federal pool for AHECs is it's federally funded. I believe you have to match 75% of it. So it's what we call a 75-25. I would have to look for specifics because I've been out of the AHEC world for a little bit. It might have changed, but the intent is that everyone puts something into the pot because we're all gaining, and the idea is to match the federal funds.
So since the federal component seems to be a pretty large chunk of it, I do wonder if we could get an idea of how much that funding has either stayed flat or gone up or down in recent years. Would that be something that could be, because I mean, if they put in 75 and we put in 25, but their 75 hasn't changed since 2000, that's, that may not be sufficient in 2020 dollars.
Right. Unfortunately, it's flipped. So we put in the 75. The states are required to put in the 75%, and the federal allocation is the 25% match. However, you can look, and I can get that information for you at the federal level, how AHECs have been funded. They have seen an increase over the past few years, but it's really not enough, but it's better than nothing.
When it comes, I'm sorry? I think you're muted.
I'm the director for Dignity of the Aged, and I have over 700 members in this organization. I'm here representing them. People are sending me messages because they know here, and they're saying things like service learning is a solution for later. We are in crisis now. You're talking about a pipeline program. Here's a survey that was just taken just recently. Top of the thing, low wages, burnout, physical issues, lack of appreciation, and coworker issues at the bottom. Are we handling any of those things when we're learning? Because those are the issues that CNAs and A's are dealing with now. What do I tell these people in Dignity for the Aged who have elderly people who are dying in nursing homes today, who were isolated because of COVID, but also Virginia was 36 before COVID even came into the picture. I understand why you're talking about a future goal, but what are we doing for the people now? For the people, my mother-in-law died in December. Another person who called in, hers died in December. He died because no one could help him go to the bathroom. We keep saying things like acuity and learning. We're talking about basic care, just enough people in one place to care for the people that are paying to be in a nursing home. When are we going to talk about those issues? And I'm very passionate about this because I hear all of these stories, and that's why I'm here. I'm representing those 700 people. Well, how can we be talking about the future helping these people now? And I am passionate about this.
First off, I want to thank you for bringing that to us, for bringing not only your members' concerns, but also their passion and your passion. As I said earlier, the work group's mandate is to come up with recommendations for increasing the workforce in nursing homes. If there are situations right now that are happening where residents are in danger or
But hang on a second. If you're talking about the workforce, then why don't we talk about pay? Why don't we talk about burnout? Why don't we talk about physical issues? Let's not talk about education. Let's talk about how we can help the people in there right now, because that is part of the pipeline.
It is. It's part of the workforce, and it is one of the things that the work group will talk about. It's part of our roadmap that we've come up with together. It's just what we were planning on talking about today is the education component of it. It will be a topic of conversation for the work group. Can you mute whoever that is?
This is Lionel DeCure. Can I make a comment?
I'm sorry, this is who?
Lionel DeCure with Dignity for the Aged.
Yes, sir, go ahead.
Yes. I want to join in with what Sam says. Right now, our loved ones are being abused, neglected, named, not eating, getting bed sores, laying in their own waste. Our CNAs are doing their best to do what they can to help everybody, but they're so understaffed, they're having to work double shifts. You know, I don't understand this approach. What needs to be taken care of now is what's going on now. That's most important. Let me ask you this. What do you think about the research and the published papers that were saying that because of staff shortages is having an impact on COVID-19? Because we're so short of staff in Virginia and the other countries, were just two papers just released by a study done in California and one done in Connecticut by several doctors, saying that because of the shortage and overworked staff, COVID-19 is spreading. I don't understand talking about the United Way and other things when there's grave circumstances and people dying. I just don't understand that. Please explain it to me.
Well, thank you for your comments. Allow me to reiterate that the work group's task is to come up with recommendations to be put in a report to be given to the General Assembly. The recommendations that we come up with, the soonest that they can be acted on will be at the 2021 General Assembly session, which begins January 2021. I don't know the exact date in January. It's usually the first or second Tuesday or Wednesday. It's within the first week or so of January. That's the soonest. Well, hang one second, sir. Let me finish. When it comes to these recommendations, that's the soonest that action's going to be taken on them. So the conversation about retention, what they're being paid, the care that they are providing, if they're getting sufficient education on what care that they need to provide, all of those things are going to be part of the discussion between now and when we turn in the recommendations to the General Assembly. So I understand and I appreciate the passion that everyone has for the topic of care in nursing homes and the making sure that our family and friends who happen to be in nursing homes are being protected and are receiving quality care. I appreciate and I hear all of that. I too have had family members who have been in nursing homes. But when it comes to the work of the work group, the mandate that we have is increasing the availability of the clinical workforce in nursing homes to make recommendations for the General Assembly, to do with what they will on it. And as I said, the soonest they're going to do anything on it will be the 2021 General Assembly session, because the report's not going to be given to them until later in this year. So I understand the desire to have. I'm sorry?
Rebecca, this is Dana. Could I speak?
Dana Parsons?
Yes.
Yes, go ahead, Dana.
Yeah, I just wanted to comment and maybe just add some perspective. I really appreciate all the comments that have been made, the frustrations, the challenges. It's a very difficult time for many, and I am so sorry for that. This legislation that brought about this work group was pre-COVID. It's an issue that we've needed to deal with for a long time. And I understand that there are concerns related to specific nursing homes and specific circumstances. And I sympathize with those matters and hope that they can be addressed. But the focus for this work group, as Rebecca has said, is to deal with the availability of the workforce. And that's something that we need to focus on, go forth with, and develop recommendations for the General Assembly to consider. The associations that are on this call are supporting our members in every way that we can. If there is a member in a nursing home that is being abused, then you need to contact Adult Protective Services immediately, but this is not the forum. I'm sorry if I overstepped, but I just wanted to try to help us recenter on the issue that we were all brought together to address.
Yes, and this is Sam Kukich. I'd like to respond to that. In January, we brought up our concerns about ratios, and we were told that part of the Senate bill was about establishing ratios or determining whether it was going to be based on hours or staff. Who in the world decided we should be talking about a pipeline of education? How did we get here instead of there?
Rebecca, may I speak? It's Scott Johnson. To answer the lady's question, the bill that passed the General Assembly, on the first line, it's very clear. It says the Department of Health shall convene a work group to review and make recommendations on increasing the availability of the clinical workforce for nursing homes in the Commonwealth. That's just the first sentence. I won't trouble you with all the rest of it because it talks about stakeholders, but that's the charge of what Dr. Pratt and Ms. Allen are leading us through today.
Bob Kukich, if I have a moment. I've taken my mask down because I think I'm more than 6 feet from anybody, and hopefully you can hear me. I think we're coming at I understand the problem. I understand the purpose. I think we're coming at the problem from the wrong end. We are addressing how to put people in the pipeline. You're never going to put people in the pipeline unless you make the occupation both appealing and financially worthwhile. The conditions today are such that neither of those exist. These people work long hours in difficult situations. Why is that? That is what I believe we should also address in this forum in order to put more people in the pipeline. The reason for that is that these real estate investment firms have taken over our hospitals and our nursing homes, and they're imposing large restrictions upon them, which make it difficult to actually staff them to the capacity that is required. The result is no one wants to work there because they can't afford to pay the people what they need to have in order to live. We need to address this problem from the back end as well as from the front end. We can't just simply put more people in the pipeline because once they get to the situation in nursing home, they find out that they have to work long hours with many people. And the reason is because the nursing homes are put under the pressure of these REITs. So I think that needs to be a part of this. I applaud your efforts to go ahead and fill the pipeline, but unless the back end is corrected, those people will fall out. Thank you for listening.
Thank you, sir. And just to reiterate, I do think we need to address the folks who are already in the workforce today. And that is, if you don't mind, I'm going to hop back several slides. That is part of the work group roadmap. I mean, even the first one that we'd come up with had recruitment and retention on there. It wasn't fleshed out as much. But that is part of what is going to be a topic of discussion. So the part about recruiting them and retaining them is about making it attractive to them to come and to stay in that staffing environment. And in terms of the roadmap, I mean, today, we started talking about the pipeline last time. We're talking about curriculum today, curriculum and debt, excuse me, both of them, so that the next, like as soon as we get into August, we're talking financing and the recruitment and retention piece of it. We'll have moved to the second half of the roadmap. So I want to assure everyone that we are going to be examining both getting them in and keeping them in when they're there, including the ones who are already in the pipeline, or excuse me, who are already in the workforce today. That is part of the roadmap. It's just that today's agenda, sorry, I hit the wrong thing. Today's agenda was the talking about the education piece of it so that we can move on to, in August, the financing piece of it, what facilities are bringing in terms of revenues and things like that, so that they can turn around and put it into the recruitment and retention piece of it. Because if, for example, reimbursement rates are too low, then it is difficult for them to be able to turn around and offer competitive salaries and wages, so that they're not going to Chick-fil-A or to Kohl's or to wherever to work somewhere else to get that higher wage or to get the other non-salary benefits that you get from employment. So I do want to assure everyone, we do plan on talking about all of these pieces of it. It was just that today's agenda was education focused, so that we can move on to the next two pieces.
Well, this is Sam. Part of it is when I looked at the agenda online, I did not see it broken down like this. It looked like the same thing from last week. And so maybe we should make that more clear, or I would have stayed on topic.
If you'll just give me 1 second, I'm going to hop back to where we were.
Hey, Rebecca, have you all thought about maybe taking, and I wasn't on the first call, so I apologize if I missed it, but have you thought about creating subgroups within this larger group to work on issues and then maybe come back to report on a future call?
We had not discussed that, but I think that would be something of value to look at. Did you have specific subgroups in mind? Or sub-work groups, I should say, sorry.
Well, I think that some of the major issues that you raised in your comment prior is what sort of triggered that thought. I heard sort of some subgroups in that area related to education, finance, and some of the other areas that you brought up.
Okay, well,
just something to think about.
Is that something that other members of the work group would be amenable to?
I guess this is Sam Kukich. In preparing for today's meeting, I wasn't really sure how to prepare, because normally I like to contribute or do some research or bring something to the table other than my Italian nature, little humor. And so I think that would be valuable for all of us to be able to bring something forward, yes, because I don't know whether I'm just supposed to listen to what you have or really contribute.
All right, thank you. And anyone else on the call?
Yes, this is Dr. McDaniel, and I concur. What I did was I went and looked at all of the different I guess, for lack of a better term, complaints that were sent in. And I actually addressed some of them and made comments. So I think that probably it would be great if we had subcommittees or something like that as well.
That brings up a good question too. I'd like to, in conjunction with that, ask a question. What do we do with those comments? What, are they just going to be compiled for later, or what do we do with them? So I appreciate you asking that.
So are you asking about the oral comments or the written ones? Sorry. The written ones? Okay. So when it comes to the written comments, those are distributed for the consideration of the work group. I know that many of them that we received in advance of today's meeting were focused on staffing ratios, there's quality of care, things that were brought up in there. Since those aren't specific things that we're talking about today, like staffing ratios isn't something that was put on the agenda for today, for example, the work group's not in a position to be able to address those comments today. But when those topics are on the agenda, I think at that point, or not I think at that point, excuse me, all the comments that we would have received to date on whatever that particular topic is, let's say in this case staffing ratios, they would be compiled, and a staff would basically prepare a summary of, like, this is what feedback we are receiving from the public about staffing ratios. It has generally not been the practice to individually respond to every single commenter, other than to tell them, like, we've received your comment, we will distribute it to the work group members, just because of the volume of comments we tend to get in. And it's a balancing act in terms of, like, how much time do you devote to the individual commenter versus continuing with the work of the work group. But for those written comments that we receive, I mean, aside from the summary that goes into the work group report, the comments are intended to be used to inform the work group members of what the public is feeling about a given topic or subtopic about what's before the work group at any given time. And like I said, for the ones that are like the ones that are the staffing ratio ones, like we will, when the staffing ratios are on the agenda, those will be comments that staff will put together and summarize for everyone. Like today we've received, let's say, 40 comments that are about staffing ratios. This many have indicated that they're for staffing ratios. This many indicated that they're against staffing ratios. For those who said they're for them, these are the specific things that they are looking for the staffing ratios. To the extent that anyone suggests specifics, we'll put those in there. Sometimes it's just I want staffing ratios and no specifics.
You know, something that might help and get us all focused more is, for example, if people knew that today's comments were supposed to be aligned with curriculum and a pipeline, maybe they would have put those kind of comments in there. When I looked at the agenda, I really didn't know what we were doing because it looked like the same thing. I mean, we didn't have all this on there. So if we could actually get people to comment on the part, okay, that we're going to discuss today, then it'd be a little bit more focused instead of all over the map, trying to get your word in, not realizing what you're going to discuss. Does that make sense?
It does. And members of the public, don't want to be too informal here, members of the public are welcome to make comment on things that, like if, for those who are, for example, attending the meeting today, have additional comments that they want to offer about specific things that either are brought up specifically on the slides themselves or come up organically as part of the conversation that's happening, they are welcome to file comments about those things as well. It's not that, oh, we've talked about Southwest Virginia education programs today and we'll never talk about them again, even if the public brings it to our attention.
No, I know that, but I'm just saying, even I was not aware that the curriculum was what we were talking about today. And you said, what, like in August we'll be talking about staffing? Is that what you said?
I mean, my hope is that in August we would talk about it.
But what I'm saying is if I knew that there was a time allocated for a specific subject, I would curtail my questions to that.
Right. Okay.
Rebecca, maybe one thing to consider, given the timing that we've got, is after today, perhaps consider publishing what the agenda topic is going to be for the next couple of meetings.
Okay.
And then as we work our way towards the end of the year, to her point about being able to comment on what's on the agenda, we all want to know what's on the agenda, but that way we're more organized as we go forward. I don't know that subcommittees are a way to go, because I think everybody that's a stakeholder on this piece of work is interested in solving the problem, number one, but hearing all aspects of it, because it is very intertwined. That may be something to consider.
Thank you.
Can I make a comment? I hope I can word this. Is this a good time? Okay. I am a teacher, and this idea of getting students to volunteer is fantastic to me, and I think that's why I asked you the question, do we have any data that it really absolutely affects what we're trying to do? So, because from my viewpoint, schools are overwhelmed with all kinds of requirements, and I see it every day and see how stressed out even the principals and everyone are with requirements. So if the requirement to do volunteer work isn't really getting the result that we want, maybe we need to look at something different. And especially, I have a budget in my household. If we have a given amount of money that we can invest in taking care of our elderly, maybe we need to go to the other end and invest it in salaries and ratios, rather than if the education end isn't paying off what we want to get. That's my comment.
Could I just follow along by saying I think the word requirement is really onerous for the school system and for teachers who already have their hands full, and I agree with you 100%. I think the way that we should be looking at this, rather than a requirement, another layer of stuff that educators and students and their parents have to do, is that there's an incentive for doing it. The governor has some special certification or gold seals, for the lack of a better symbol, that can be added to high school diplomas to recognize those young people who have decided to take it upon themselves. Not that it be a requirement, but that they sign up to do some of this service learning. And we know that our young people are extremely interested in their elders. We know that they see this opportunity as something they want to do. And I would hope that as we go forward and as we come out with some recommendations, they be just that, recommendations, not for requirements, especially now, trying to figure out how to go back to school and how to do things in the fall. Not that our report won't be done by the time they go back to school, but to look at the programs that have been successful and to look at the students that have had meaningful experiences, I think speaks exactly to what you just said. And I just wanted to say amen.
We did have a request from sorry, this is Rebecca. We had a request from someone on the line that when muting and unmuting, to make sure that you identify yourself and your organization, just as a reminder. And I will say as to the optional or the non-required part of it, you know, just one more requirement that's being stacked on students. Certainly with the service learning piece of it, it is the trend that it is an optional one. Like I said, DC and Maryland are the only ones right now that it is a requirement at the state level. The majority of them, either it's at an optional state level requirement or it's an optional local district requirement. So I do apologize for bringing the conversation back several steps to the Southwest Virginia Rural AHEC, or just the AHECs in general. The one thing I wanted to ask about, I think this is what my other follow-up question was, is the programs that they've come up with here in this particular AHEC, is there a process by which it has to be, like does the federal government have to sign off on it? For example, like, does the state come up with a plan, or not the state, the AHEC come up with a plan, submit it to the feds say, yes, you can spend our money on that, or is it some other way?
Oh, this is Heather Anderson. This is probably all part of a federal grant that is written annually. It is updated, but it's written on a 5-year plan, and in partnership with medical schools in the state, and so they individually will come up with their plans, and then it is included as part of the federal grant that then the feds distribute the funding that the state has to match. There are also local initiatives that each AHEC could do, and each one probably does at different levels based on funding and interest at the local level.
All right, thank you. On the topic of curriculum, I know we'd received some information from the, Dr. Pratt, it was the Department for the Deaf and Hard of Hearing? Yes. Is that correct? Is a representative from that agency on the call right now? I think it's Karen Brim, isn't it? Is Karen Brim on the call? You see her on there? Well, in Ms. Brim's absence, I will have to rely a little bit on Dr. Pratt for this, but one of the things that you may recall that we talked about last time is curriculum needs. So in terms of the deaf, hard of hearing, blind, vision impaired communities, there are particular ways that they can be, that we can work on getting them into the pipeline. One of the things that the Department for the Deaf and Hard of Hearing had mentioned was there is in Minnesota, it's called the Minnesota Employment Center, but they have a very robust model that they use as a business, as a resource for businesses, in addition to a resource for employees who are deaf, hard of hearing, blind, or vision impaired, to connect them with employers and to help educate employers about having those individuals as part of their workforce. this is outside the discussion of curriculum, but one thing that we will circle back to on this particular workforce is that the federal government, for example, offers certain tax incentives to employers of individuals from this workforce. So one thing in talking about the financing component would be not only a brief overview of what the feds do in terms of tax incentives, but talking about what tax incentives are present, which I'm not sure, I haven't done the requisite research at this point, what incentives the Commonwealth of Virginia offers on that particular point, and what maybe could be recommended. Did you say, Dr. Pratt, that you'd received something from the Department for the Blind and the Blind and Vision Impaired?
That response is pending.
Pending, okay. Then we will put them on for next time. So, and we will try to make sure that the Department for the Deaf and Hard of Hearing have someone that they can talk more in depth about this, because it is outside of my area of specialty.
And I believe that our representative today had a conflicting meeting from Department of Deaf and Hard of Hearing. Excuse me, Blind and Vision Impaired. She had a conflicting meeting.
So we'll circle back to that topic at a future meeting date. And other special needs, I know Mr. Barnes is on the line since he spoke up earlier. So the Department of Veteran Service had provided to us a list of training competencies and general knowledge that they felt need to be included in the curriculum in terms of serving military veterans. And I also wanted to make mention as well of the Virginia Transition Assistance Program and the Military Medics and Corpsmen Program. Mr. Barnes, are you on the line still?
Yes, I'm still here.
All right, thank you, sir. For those of us who either haven't had folks who haven't had family members who have been in the military who transitioned out to civilian careers, do you mind giving a little bit more detail about VTAP and the MMAC program?
I'm sorry, about the what now? Can you repeat that?
Yes, could you please give some background on what the Virginia Transition Assistance Program is and the Military Medics and Corpsmen Program? About how that...
I'll probably have to get back with you on that, as okay. I've only been here with the administration for a year. I don't want to speak out of line and not give any false information, but I'd be glad to get enough to you. I just don't know that I can speak well enough to inform you without having my facts with me, but I'd be glad to get that together for you for the next meeting if you'd like that.
I would. And one thing I think that would be of value to know in terms of coming up with recommendations from the work group about the education pipeline, because this is a education career transition point where someone has been in the service, they are coming out and are rejoining or joining for the first time, depending on what it might be, the civilian workforce. If there are any recommendations or feedback that you've gotten from your subject matter experts at the Department for Veteran Services, about gaps in the existing programs that you have and the and ways in which the state might be able to remedy that to make to basically make the transition to a career in the clinical workforce a more attractive proposition, and if there's anything specifically that about not only the clinical workforce but the nursing home workforce, that would be helpful to know.
Yeah, we have a lady, a deputy commissioner that's over that entire program for us, and she has all that information. So I'll be glad to get a lot of information from her for you for our next meeting.
All right, that sounds great. Thank you. Okay, so.
I just want to make a comment here. Sure. This is Sam Kukich from Dignity. Being a veteran, I'm telling you right now, veterans could get the nursing homes in order. They have discipline, they're organized, and they know how to get the job done. So I think if you got some veterans involved in here, that would be an excellent idea.
All right, thank you. Actually, before we move off the subject of veterans, Corey Tillman-Wolf, are you still on the line?
I am on the line.
Okay. Hi, Corey. Just as a reminder for everyone, Corey here represents the Board of Long-Term Care Administrators at the Department of Health Professions. Corey, do you know if the Board of Long-Term Care Administrators has any programs for administrators who are coming out of the military into civilian services, or anything targeted specifically to that population?
The board doesn't have anything that's specifically targeted to that population, but you know, we certainly do have military applicants who come into the pipeline to become administrators in training and then eventually administrators of the facilities. But in terms of the board itself, we don't have anything that specifically creates a pathway for military veterans other than our general pathways.
Okay. With the facilities that the administrators are in, do you know if, just as a general matter, and this may be something that you need to ask your board, it may not be something you can answer today, do you happen to know, when it comes to the nursing facilities that are out there today, how many of them are, I'm trying to think how to phrase the question, are specifically looking to recruit veterans, or who have tried to, who are aiming to make their place of employment a more attractive place to work for veterans? Do you know of any such?
You know, I don't have that information offhand, but April Payne with BHCA or even Dana Parsons with Leading Age may have some information among their membership where there may be some programs in place to try to bring military veterans into the pipeline. So I would defer to them on that piece. We don't have any of that information on the board end.
Okay. Dana, are you still on the call? Dana or April? Sorry.
Yeah, this is Dana. I'd have to look back and compile that information from our national association, and could get back to you on that.
Okay. If there's been any, like I said at the beginning of the meeting, Melissa Andrews at the last work group meeting had talked about some initiatives that other Leading Ages in other states had done in terms of like engaging middle school students and high school students.
Yes,
yes. Yes. If you could let me know if there are programs either in Virginia or that other Leading Ages are doing in other states that are targeted towards veterans, that would be helpful.
Absolutely. I'll get that to you.
Here.
Ms. Allen, if I may, there are a couple of programs that I'll mention at the state level. One is called Virginia Values Veterans V3 program. It's an informal program whereby an organization agrees to make a concerted effort to hire veterans for very good reasons that have all been put on the table earlier today. So that's at the state level. And then to speak quickly to the MMAC program, the Military Medics and Corpsmen, Virginia was the first state in the country to recognize the unique skill sets that transitioning corpsmen and military medics have coming back to civilian jobs. The way things were set up at first, they had to wait for a long time. They had to get re-credentialed in their area of expertise, and we realized what lost time and talent that was. So some years ago, Virginia put in place this Military Medics and Corpsmen program, and it has been wildly successful. It started out as a pilot. It is now made a permanent program in the state of Virginia, and we can bring, and I'm sure that we can have more information presented on that program at a later time. But those are two state-level programs. There's no reason that nursing homes couldn't participate in those.
Yeah, this is Todd Barnes. I wanted to say again, all of those programs, they really are wonderful, and the VP3, the VTAP, and the MMAC program, and there's so much information that I said I could give with you, and I'm going to try to get all that stuff together from our specialist who does that, because we've utilized that quite a bit in our veterans home in our Richmond area. We've been fortunate here. I'm the administrator at the Roanoke area, and we've been very fortunate in our staffing and things, but we do make a concerted effort to try to recruit veterans. So I'll be glad to get all that information together for you guys, and maybe even just put a PowerPoint together or just some basic information and shoot it out to you, but also have it ready for our next meeting. I'll be glad to get all that for you.
Well, it came back. Okay. Apologies, we had the mics go out here for a second. All right. Okay, so we will, Mr. Barnes, we will follow up with you and have additional information about this. And then, Dana, I will also contact you after the meeting about seeing what information can be gathered about Virginia nursing facilities doing specific outreach to the veteran population in terms of getting them into the workforce. Okay?
Okay, great. That sounds like a good plan.
All right. Thank you, Dana. All right. Actually, let me back up. Does anyone have something they want to say about the curriculum piece before we move on? I know that we will revisit a small piece of this at the next meeting at the beginning of August, so that we have the departments for the deaf and hard of hearing and the blind and vision impaired can speak about their specific piece. And then, of course, Mr. Barnes and Dana Parsons talking about the veteran piece of it.
If you could speak up just a little.
Sorry. So before we move off curriculum, I know that we'll have a piece of this that we will revisit at the next meeting for the deaf and hard of hearing, blind and vision impaired piece, and then the pieces that Dana Parsons and Todd Barnes will bring in. Other than that, is there anything else anyone wants to say before we move off curriculum?
I have a question. So I think this is a great idea with respect to incorporating veterans, because I said they are a motivated group of people. We've learned to live everywhere and get a job done. So is this specifically, this pipeline is specifically for nursing homes?
Yes. So there are, I mean, as Dr. Pratt mentioned, and Mr. Barnes, I'm sure will elaborate on the next work group meeting. These programs specifically, the two that are on the top here, these are not nursing home specific, but the reason why I want the component piece from Dana about what facilities are already doing is figuring out ways that using the existing programs that are out there, what can be done to increase the utilization of those programs by nursing homes, and then if there are gaps in the programs that are leading to nursing homes kind of falling by the wayside or not being an option for folks who are transitioning out of the military and civilian service, recommendations that we can make to fill those gaps. Both of those pieces, yes.
Rebecca, this is Scott Johnson. You may want to consider reaching out to Jay Douglas, Executive Director at the Board of Nursing, because the General Assembly has passed legislation to, in essence, recognize military corpsman training to be an equivalent in certain areas for different nursing positions. And they also, I think this past session, passed legislation to do that for spouses of military that transfer here. And so it may be good to get an update on that just to make sure we know what that is and maximize it.
All right, that sounds great. And I think they just did this past week or two, I think there was a ceremonial signing of that military spouses bill, because I got an email about it. Actually, is Charlotte Redoubt on the line still? She's with the Board of Nursing, sorry.
I am.
Mr. Dowd, do you think that for the next meeting, since you're here for the Board of Nursing, that you could speak to that particular topic about the changes in the law that have been made regarding military medics and corpsmen? Or
Absolutely.
Okay.
Yes, I'll be prepared to do that then. Mm-hmm.
All right. Thank you.
Thank you.
Anything else on curriculum before I move forward? Hearing nothing on the line. You good? Okay. All right, debt. So this is educational debt. Dr. Carter and her wonderful team over at the Healthcare Workforce Data Center, the 2019 report that they had done on LPNs and RNs, which you may recall there was a snapshot of that on the last meeting agenda. If you happen to look at those, the full reports themselves, in there is a snapshot of what educational debt load is being currently held by LPNs and RN. So for the LPNs, it's 42% of the respondents to the surveys say that they're carrying debt. In terms of your under 40, that jumps to 60%, and the median debt is between 20 and 30K. For your RNs, 41% are carrying debt, and your under 40 is also 60% who are carrying debt. And their debt is a little bit higher as well. Median debt, 30 to 40K. And again, these are self-reported numbers that Dr. Carter and her team collect when folks are renewing their licenses. So when it comes to educational debt, there are programs out there, which is why I'm so glad you're here, Heather, because I know that the Office of Health Equity here at the Department of Health runs at least one program, if not more, about loan programs and debt forgiveness, and I think one of them is this one. But if there are more, please do expand upon.
Thank you, Rebecca. Yes, the State Loan Repayment Program is one of the solutions to debt. It is a very successful program that we have been running in the state of Virginia for several years. This past year, loan repayment, so there's federal funds that are given to the state, and then a one-to-one match is required, and that can be done either by the facility that is hiring the person, or it can be done through state funds. And this year we had a mix of state funds as well as the Tobacco Commission put forward some funds as well, so we were able to expand opportunities. Unfortunately, none of the recipients work in long-term care facilities at this point, so there's an opportunity for us to make a specific recommendation about this because it's a very successful program. The state loan repayment is available to RNs, pharmacists, nurse practitioners, psych nurses, and then physicians. So if we wanted to do something as well, specifics for CNAs and well, I'll talk about LPNs in a minute, but if we wanted to make a recommendation specific for other levels of nursing, LPN and CNAs, we could do that as well. There's a second program that's also available, and it is the Nursing Scholarship Program that has been around in Virginia for a number of years. That is available to LPNs and RNs. Now, it is a scholarship program. It requires service component after the scholarships are granted, but it is also a very successful program, and that could also be a solution. The catch is it is not currently funded. So, but these are opportunities for us.
So I heard you say RNs, yeah, just keep the mic with you. I heard you say RNs, LPNs. Is there anything on, is there anything restricting someone who has, let's say, gotten a loan or loan forgiveness or debt forgiveness as an LPN, preventing them from using it again as an RN if they go back and?
I would have to get back to you on that. I don't know the weeds of these programs, but I could certainly find out that answer.
And Dana, are you still on the line? Sorry to keep circling back to you.
Hi, this is Dana. I'm sorry. Did you ask for me? I apologize. I had to step away.
No, it's all right. Last time we had a work group meeting, Melissa had talked about the advanced CNA program that you all have.
Yes.
Yeah, so what's the funding structure on that? Is there debt being taken on?
No.
Potentially, is there debt being taken on? Sorry, let me rephrase that.
Yeah. Oh, thanks so much for the opportunity to talk about that. Just to recap, I know Melissa had brought it up on the first call. We received a grant from CMS to create a curriculum for approved by the Board of Nursing recently for CNAs to become advanced CNAs. And Blue Ridge Community College is offering the course. It starts on August 18th. It's completely scholarshiped through the grant. There are 10 students that can attend per semester. There are currently 4 slots open, and there will be no debt. It's all paid for through the grant for the first 3 semesters of the program.
Okay, and with I guess the follow-up, well, a couple follow-up questions. How long, the grant, I'm sure, is not of a indefinite length. When the grant ends, is the plan to secure financing some other way so that it remains a no debt program? Maybe no debt.
Well, I know there's been some interest expressed in other parts of the state to apply for CMP funding to implement this program in other parts of the state. But the plan is to, over the next 3 semesters, it will be scholarshiped. The curriculum will be tweaked as Blue Ridge Community College implements the curriculum. So once the 3 semesters are over, the curriculum will be available to all nursing homes in Virginia to implement, but there will not be any additional scholarships unless another organization obtains a grant, CMP grant, civil monetary penalty grant through CMS.
All right, thank you, Dana.
And that is some options through that grant that you might want to make recommendations from this study to go after funds to implement.
Okay. A question I have for you, Heather. So the state loan repayment program, the one that's RNA, in terms of nursing, it's for RNAs, not LPNs, right? So since it's only for those who are serving in a health professional shortage area, are there any other loan repayment programs or debt forgiveness or anything like that for folks who are not in those areas?
Not at this time, but that, again, could be a recommendation specifically for long-term care facilities.
Okay. Because I mean, this is just a guess without looking at the map. I'm sure it's including a lot of the big localities. So like Richmond's not going to be one, Northern Virginia is probably not going to be one, et cetera.
Well, health profession shortage areas, you'd be surprised, there's a lot. And depending, I mean, mental health, it's practically the whole state. Right. Primary care is a little bit less. So there are also areas called medically underserved areas that are governor designated. Mm-hmm. And again, that's an opportunity for us as a work group to look at and possibly make a recommendation specifically for long-term care. It's possible if we were to use the health profession shortage areas that there could be some facilities that are not within a health profession shortage areas, so we would want to be careful at the criteria we use.
So for the you said medically underserved areas, mm-hmm. How does that play into the loan repayment program?
Usually the health profession shortage area trumps it, but they're usually the same thing. The medically underserved area is generally about a population. So it looks at women of childbearing age and things like that. So it's pretty specific, but they're usually the same places.
I was just curious about that. So so you said that not this program, what was the other one that you said, the one those LPNs?
The scholarship?
Yes, that scholarship. So that is gotten at the beginning of the educational plan.
Yes, that's while they're still in school. Okay. They get scholarships, but then they agree to having to do service, and they line up their service opportunities. So that would be a way to, fund the pipeline that we're talking about.
And that's only LPNs? It doesn't include RNs as well?
It's RNs as well.
RNs as well.
Mm-hmm.
Might need to do a chart on this. And that one's not funded. This one is funded. Now, is it like the Southwest Virginia thing where it's some mix of federal and state funds, or is it just state monies?
No, so this is a mix of state and federal funds as well. We get a federal grant, and the federal funds are required to be matched. So, for instance, if somebody has requests, and there's an application process, but let's say somebody has $20,000 in debt, and they ask for us to repay that $20,000, we would match it federally, and then the state or community would have to come up with the other match, or the recipient can come up with the match themselves as well.
So the trying to think how to phrase the question. Hang on a second. For those who have, I know you said there's none right now who are in nursing facilities, but there have been in the past?
I'm not sure about that. Probably not.
Probably not. Do you have, I mean, it's speculation, I'm sure, at this point, but do you have any feel or reason or guess as to why it's not been nursing facilities traditionally that have been taking part in it?
My guess is they probably don't know it exists to use it as a recruitment tool. So because it's a mix of funds, well, this would be true even if it was just totally state funded, because the other program, there's no funding, state only, correct? It's only the state. Right. For the nursing scholarship programs, the Board of Nursing puts in $65,000, but then that's it. There's no other funding. So there is a short amount of funding that's available, but that doesn't come from the state. That comes from the Board of Nursing.
Okay. And Charlotte, are you still on the line?
It's Charlotte.
Charlotte Riddell.
This is Charlotte.
Hi. So quick question. The scholarship fund that Heather's talking about right now, the monies that the Board of Nursing puts into it, do you happen to know if those are general funds or if those are non-general funds? That's what I thought, but I want to check.
That money comes from when nurses, a dollar of the renewal goes into that scholarship fund.
Okay, so that is so it's fee supported.
Yes.
Okay. So now this is going to be a question more for the Board of Nursing. My understanding from having previously worked for a regulatory board, not one in DHP, but another one in the state, is that DHP's boards are, for the most part, fee funded. There's very little in the way of general funds that you all get, that it's the fees that tend to cover the cost of your employees, the cost of Vita, the computers, et cetera. It's mainly fee funds, right, from licensing fees?
Correct.
Okay. And if I recall correctly, there's a rule on the books. It's in Title 54.1. It's been a long time since I've looked at it. I think it's in Chapter 1 somewhere. But basically, if your fees that are coming in exceed more than 10%, I think, of your operating budget, I think you all have to drop your fees, correct, to make sure that you stay under that cap?
That's correct.
Okay. So with
and
your
we recently had to do that, and there for the past 2 years we had, and then now we're back to where we were for almost all of the licenses, but they're coming back. So yes, we do that.
Okay, so the cap, like I said, I think it's 10% of the operating budget. The monies that you all are putting into the scholarship fund, is that considered part of your operating budget? I would hope so, but I could be wrong. You happen to know? It is?
It's my understanding that it is. I can double check on that.
Okay, because I'm wondering if, in terms of a potential recommendation to have that scholarship program funded, if there is something standing in the way because of the way the fees and the money is coming in and out of the Board of Nursing are structured, that, you know, you've got that 10% cap on you. I'm wondering if that's a potential stumbling block to having that funded. So if you could look into that, I would appreciate it.
Yes.
Can I ask a quick question? Here. This is Susan Hines with Dignity. I was interested in that advanced CNA program she was talking about. Do you know how that is different from just any CNA program?
Dana, are you able to answer that for us?
Yes, this program is very different in that it's creating a career ladder for communities to implement within their nursing home. It's different in that the course focuses on 4 objectives: leadership, care of the resident with cognitive impairments, restorative care, and wound care. So those are the 4 areas of focus. Are there any other questions I can answer?
So these CNAs are able to do more than the basic CNA training, is that correct?
Yes, we have a website that we are creating. It's going to go live soon. That has all the course, has team building, effective communication with the healthcare team, care of residents with cognitive impairments, wound care, positioning strategies, transfer techniques, preventing pressure ulcers, restorative care. Those are just some of the areas. Once our website is available, we'll definitely share that and can send that out. If anyone is interested in getting an application for a CNA, you can email me at dana@leadingagevirginia.org. And to be eligible, you have to have current certification as a nurse aide in Virginia for the last 3 years. And then there's some other criteria as well, but I'd be happy to share that with anyone who's interested.
Thank you. Do you know if that puts them in a different pay bracket?
Well, that's going to be up to the communities. That's something that we're talking to them about, because it will definitely have to put them in a different pay bracket.
Okay, thank you.
Mm-hmm.
Does anyone else have questions about the advanced CNA program?
This is Charlotte with the Board of Nursing.
Yes, go ahead.
Yeah, there are some criteria, as Ms. Parsons was just saying, and they are in the regulation for states regarding the criteria for advanced CNAs, and then as well as some of the activities that the advanced CNA can perform.
Okay. All right. So in terms of the loan programs, from what I've heard, just to sort of sum up what you said, is we have this loan program, mix of federal and state funds, right now limited to RNAs, and it's a once you're out in the workforce program. Correct.
Loan repayment, yes.
Okay. The loan repayment program. I do apologize. And if the state, if I understand you correctly, it's possible that the state has the authority, I guess, if they had legislation passed, that they could expand it to LPNs, which it currently does not apply to.
Yes.
Yes, okay. So that's a potential recommendation.
Yes.
And then the other one, which was the scholarship program, that's LPNs and RNs, but presently is not funded at all. It's an unfunded, I don't want to call it an unfunded mandate, but it's an unfunded program here at the state.
Well, it's funded from the Board of Nursing. It's not funded
Anywhere else?
anywhere else.
Okay. And the funding you said was like around 65K, thereabouts?
I believe so. I could check. I think it's about 65,000, and we, of course, have more applicants than
It is.
normally.
Right. Okay. Understood. And that's as you're coming into the program, sort of funding solution, because it's a scholarship.
Yes,
Sure
it's a scholarship program, yes.
Is there a limitation on when it can be applied for? So let's say I come in, I think I'm going to get a history degree, and I don't apply for it my first year in school or my second year, and I do a major change, and then I want to go get that credential. Am I going to be barred from it because I've been in school too long, or
You have to be accepted into a nursing program.
Okay.
And you have to have faculty recommendation as well as financial aid recommendation for the application packet. So we have to know that, and there's an essay required too. So somebody, in order to get the scholarship portion of this, it's pretty sure that they're going to fulfill their nursing or their obligations.
So you said so there is a need component to it?
Yes.
There is a need component, okay. Scholarship programs can be kind of complex. Is it is need a weighted consideration, or is it if you don't have need, you're totally out of the running?
I would have to get back to you on that answer. Yeah.
Like all those questions students come in with.
Yeah, I mean, I can let you know. I do know that there has to be a recommendation from the financial aid office.
Okay. I just wasn't sure if it was a knockout punch if you didn't happen to have that particular scholarship opportunity. Okay. And as you said before, it's limited by the money that's there, and there's just not a lot of money there. In the past, was it a general fund appropriation that was added into whatever Board of Nursing threw in? Do you know, or if it was a special?
I think in the past there may have been general funds for it.
Okay.
But in my tenure, which is 5 years, there hasn't been.
Okay. Just checking. Just wanted to ask. Okay. So other than those two programs, the loan repayment, which is sort of the back end, you're already out in the workforce, and the scholarship one, which is you're coming in, are there any other state-run programs that we have that can address educational debt that you know of in health equity?
I don't think so. There are other incentive programs that we manage, but they don't necessarily address educational debt.
Okay. What are those other incentive programs?
We also manage what's called a J1 physician Conrad 30 program. It's for international physicians to come to extend their visa to work in an underserved area of the state, and then at the end of their obligation, they're recommended for citizenship and to work in the country.
Is that physician only? Is there a nursing component to it?
It's physician only. Okay. It's federal legislation, and it's capped right now at 30. I do believe they're looking at expanding it. So there's nothing else. At the federal level, there is what's called a Nurse Corps, and there's a National Health Scholarship Program and a Nurse Corps Scholarship, which are similar to the loan repayment program we've discussed, but those are federally based programs.
Do you know of other states' programs that might be a model that we could pull from in terms of addressing debt?
I do not, but I know my coworker, all of that, might know, and I can get back to you.
If you would, just so that we can make sure that we've not only addressed the options that we do have, funded and unfunded, but also maybe pulling from other states good ideas that they've had.
Happy to do that.
All right, that sounds great. Does anyone have anything else they want to say about educational debt? I know that can be quite a drag on someone and can be a driver for getting them out of a nursing home where they're not being compensated enough to make.
Yeah, I have, Bob Kukic, I have a question. Had these slides been provided to us prior to this, we could have then asked questions of the person who provided the slide. I think we're taking up a great deal of time going over a territory that could have been provided in a subgroup or whatever. So I would like to applaud that recommendation by whoever made it because I think we're just beating a dead horse at this point. Thank you.
All right. Anyone else? Is there anyone else on the call that would like to say anything about educational debt? About potential recommendations for either new programs that we can look at, or alternatively that you know of programs such as the loan repayment program where there are gaps that we can recommend filling in. For example, recommending that LPNs be added to the program.
I just want to add, it's interesting. I wish we could talk about the debt that the families go into trying to pay for nursing homes, because that's a real issue at $8,000 a month. Well, that's outside of the discussion on educational debt, but the healthcare financing piece is next on the roadmap. And while it was, the things that we have on there now are more facility focused, so like your reimbursement rates, your payer mix and things like that. The payer mix and reimbursement rates tie directly into what families are paying as well. So I think that can be included as part of the conversation there. Excuse me.
I have a quick comment. This is Susan Hines with Dignity. As far as CNAs, what they pay for school is much lower than nurses or LPNs. But I know when they do finish school, if they went to school, let's say for Riverside as an example, if you go to a Riverside nursing home, you don't have to pay for your schooling. So I can imagine that the state could come up with possibly something where if you were going to switch companies, they could pick up the cost of the schooling. It's just a thought off the top of my head.
I think that's an excellent suggestion, because what we've talked about so far is LPNs and RNs, and of course the advanced CNAs, but that's not your, I don't want to say your regular normal CNAs, but you know what I mean, just, so yes, I think that is something that could be looked at as a potential suggestion, and it may be that other states might have a program that they've already piloted or modeled that we could use as a base for that sort of covering of CNA debt. The reason I didn't include a CNA debt on that one slide that I had is that the questions that were asked by the Healthcare Workforce Data Center didn't have that in there for CNAs, which is why it wasn't included on the slide. But you are correct that they do have debt that they have to address as well, even if it's not as much as what the median is for LPNs and RNs. It's still a debt, and if the salaries and wages are low, it's definitely a burden. So, did you have something, Heather?
Well, this might be more for recruitment and retention, but there are other professional or health professions that have a hard time recruiting as well into long-term care facilities that are not covered within the incentive programs that I've talked about: physical therapy, occupational therapy. I'm assuming they're hard to recruit for these areas as well. So when we get to that part of the discussion, we might want to think beyond the nursing categories as well and make sure our recommendations are comprehensive.
I would be happy to follow up with the leadership over at the Department of Health Professions to see if we can get someone from those boards, because right now we have Board of Long-Term Care Administration, Board of Nursing, as well as Dr. Carter with the Healthcare Workforce Data Center. So I think they're definitely having their input, because I don't think you're wrong. I don't think your gut instinct on that is incorrect.
I have a question. You just said something that sparked a thought. So with regard to the different categories of workers and all of this in the workforce for medical, is there a percentage of nurses, doctors, what percentage is lacking most? Because from our perspective, from the 800 people I'm representing, they don't have enough hands-on CNAs. Are you saying that, have they looked at the percentage of the workforce that is most in need, or is it just the whole gamut?
I think each profession's going to advocate for their profession, but there are different ways of looking at it, and I think we've heard for a while that it's a distribution problem, not a numbers problem as far as health professionals, doctors, nurses. I'm not sure that that's exactly true, but we've had health profession shortage areas. The criteria that we use for these payment programs, they've been around for 30 plus years. So I think the shortages, we call them chronic and long-term. And so it's a greater problem than just the numbers. There are professions that require less education where there might be more folks available. And I mean less in years, not less in time, but they move around more. I mean, you know, so it just, I think it just depends on how you look at it.
Right. Well, I guess I'm looking at it from the nursing home perspective. And I would say that most people that I have talked to and surveys I've read and research I've done have constantly reiterated the fact that staffing is, that people are understaffed and burned out and not paid well. So that seems to come up more than anything. So what I'm saying, instead of looking at the whole picture of nurses, LPNs, blah, 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 if we're looking at nursing homes specifically, and we're not necessarily, you know, I've heard the word acuity a lot. Okay, and I understand that, but let's say instead of looking at acuity, if you look at 10 people and they're all maybe one person is more severely requires more care than the other 9. Okay, but the thing is they all need basic care, so you're not really going to get away with the acuity aspect of saying, well, we need them because this person needs more help, because they all need help, even though it's simple help. So why aren't we looking at the perspective of nursing homes and seeing it that we need, that we look at the pipeline, if you will, based on the people that, the CNAs that are doing the backbone of the work. It would just seem that we should look into that aspect of it, because that's the most hurting part. You know, one of the Dignity members came up and said, you know what, my father died because he went to the bathroom on his own. There was no one to help him. He got back in bed. The nurse yelled at him for getting out of bed. He tripped. He fell. He fractured his foot. They didn't realize it. He ends up going to the hospital. They bring him back to the nursing home. They forget to plug in his oxygen, and he dies. Now, he died because he didn't have anyone to help him go to the bathroom. Now, that's not an acuity thing. He didn't need a lot of help, but he just needed basic help. So if we could look at it from the nursing home point of view and take care of the backbone of workforce, we might really work together in helping that workforce as well as the elderly at the same time. I guess that's why I'm here. And if you're talking about debt and all this, a lot of the CNAs, as I think Susan said, doesn't cost a lot to go to training for a CNA. So if we could do what we can do to pay them more and look at that element, we don't need to look at the whole medical field. If we're looking at nursing homes, it's not a secret. They really don't have enough staff. And that's what I'm saying. I understand your whole picture and all of it. But right now we have a problem that we can't put a Band-Aid on it anymore. We really need to look at the CNAs. Is there a way we could do that and fix that part? If we just had people in the nursing homes who could be helped now, looking at that part, I think you'd fix the other part. Instead of approaching the whole thing.
Well, I think this is our opportunity to do that, to look at the nursing home part. And my role here today was to bring forward incentive programs and opportunities that we have, to give examples of opportunities that we have in place in other areas of workforce, to look at those as examples for solving what's going on in nursing homes.
Thing is, and I'm not trying to be argumentative, I'm saying if we looked at the part that where it's bleeding the most, and that is with CNAs, we could help the elderly as well as develop a better program. Instead of trying to fix the whole car, let's just change the tires so it moves forward. I guess that's what I'm saying, because right now there are people dying, and they just need a CNA. Well, I don't have the knowledge or numbers to say whether it is wholly a CNA problem or I don't disagree with you about needing more CNAs. I do not disagree with you at all on that point. I don't know that there isn't also, let's say, a rising LPN problem as well. And we're just not seeing it because the CNA one is right there. It's already bubbled up to the top, and we're seeing it now. I would want to get that information so we know what the numbers look like in terms of what is the need for CNAs, what is the need for LPNs, what is the need for RNs, so that in making the recommendations, yes, there needs to be CNA-focused recommendations because, you need boots on the ground to be doing that basic care. But I think it would be, I think the work group wouldn't have met its full potential if it focuses solely on CNAs. I think we also need to take the opportunity to try to bolster the LPNs and RNs who are also serving there, because the bill doesn't say just CNAs, it just says clinical workforce. So I think there's value in making sure that we address the other types of nursing as well. But yes, there does need to be attention paid to the CNA problem specifically. Well, excuse my passion because I don't mean to be this way, but I just feel like when someone tells me their father died because they couldn't get a CNA to help them go to the bathroom, part of me says, oh, please. So, and I hear a lot of those.
Hello?
Hello, who is this?
This is Dr. McDaniel from the Virginia Nurses Association. If I may interject.
Of course.
Now, I don't know, but I think that most of us know that CNAs do provide approximately 90% of the care in long-term care facilities. And I have that data from a few researchers. My concern is that there are not enough geriatric specific education for any of the workforce. And I think that we are going to continue to have problems if we don't address that. We have nurses who work, we have licensed nurses who work in long-term care, but they have no training in geriatrics. And we also have CNAs who, as you know, for the state of Virginia, I believe is still 120 hours of training that they receive. The federal mandate is for 75 hours, so I'm grateful to Virginia that the hours are more. But my biggest concern is that, and along with the fact that there has been no attention to CNAs and the training since, I believe, 1987, if I'm not mistaken. And of course, the acuity level of patients has increased tremendously. So one of my biggest concerns is the lack of geriatric specific training for all of the workforce.
Thank you, Dr. McDaniel. The numbers that you referenced, would you be willing to share those with the work group?
Absolutely would.
Okay. And as part of the, I'm sorry, who's it?
I'm sorry, it was Charlotte Rideout from the Board of Nursing.
Yes, go ahead.
Yes, I just wanted to say that, yes, Dr. McDaniels is right with the federal regulations have not been changed since the late 1980s. The Board of Nursing in Virginia, we just last year updated our curriculum for CNAs, and the 120 hours is a requirement in that mandated curriculum. That
Charlotte,
curriculum
okay,
CNAs is on the Board of Nursing's website for review.
thank you so much for that, Charlotte.
Thank you.
I was trying to figure out if they actually changed them, because I know that one of the recommendations that we had for the task force was to change them to 140 hours. And
that is.
Go ahead.
No, I'm sorry. I thought you were finished. It's hard to in this format. I'm sorry. Yes, Dr. McDaniels, that is correct. You were part of that workforce or that curriculum committee. So they did recommend 140 hours. That was met with many comments from the public, and that was going to be a hardship for many people, they felt, both educators and the facilities themselves, to be able to provide that amount of hours. So the board listened to those public comments and went with the 120 hours.
Yeah, I thought that might end up happening. Well, I'm going to just say, as you know, you have heard from Dr. Paula Saxby in the past, that we both have heard this, that it's appalling that it takes, I believe, 1,500 hours of training for cosmetologists to get a license to do nails and to do hair, and only 120 hours for people to take care of our geriatric population. And I just have issues with that. Of course, you know that.
Yes, you are correct with those hours.
If you don't mind me interjecting, the workforce, the curriculum work group that you all are referencing, was that a report to the General Assembly?
It was a curriculum committee composed of DHP staff, Board of Nursing staff, and stakeholders from, and that included educators and some other people from other stakeholders, and Leading Age, I believe, was involved, and some other.
Charlotte, I thought that the first that the email that I received came from one of the delegates, though. So I guess I was a little bit surprised that it wasn't. There wasn't a final report, because I thought that it did. Can you find out, or is that important?
Well, the reason I asked if it was a General Assembly report is I was going to look it up after the meeting, because
no, I do not believe that it was. But I can certainly double check on that. That was, yes, I can. Okay. General Assembly report, as I remember.
Okay. All right.
May I interject something here? This is Susan Hines from Dignity. The most shocking statistic that I read this week in regard to elder care has to do with this CNA situation. And I was glad to hear the doctor say that 90% of the care is done by the CNAs. The number that I read of deaths because of infections was between 380,000 and 500,000 per year of our elderly who reside in nursing homes. And that goes right back to our shortage of CNAs, because they're the ones that clean these citizens up and take care of those things that are going to keep the infection from happening. And here we are, we're so worried about COVID, which has already killed 138,000 as of yesterday, and yet every year 380 to 500,000 are dying, and we don't hear it on the news. It's not popular to report, but it's so basic that we need so many more CNAs to take care of these people. It's heartbreaking.
I just want to add to that. This all started for me several years ago, and so Dignity evolved because I didn't know about this before until my mother-in-law experienced it. But I really thought when COVID came out and it was about the nursing homes and it was about how the people at the nursing homes were dying, and I thought, well, you know what, this is sort of blessing in disguise. The attention will finally come out. The nursing homes will finally get the attention they deserve about the lack of staffing and some of the things that result because of the lack of staffing, the neglect and the abuse and the death. And it just seems like it doesn't matter. I mean, I don't know what else has to come out for this truth to be told. It's out there, and there's nothing. Two hands can only help so many people. You can't take care of 30 residents. I mean, Aaron, how many residents do you take care of? I mean, how's that working for you?
I usually take care of 18 by myself, and they just get very, very minimal care, even though I'm on my feet for the whole 12 hours. And also, I would like to speak to what Ms. McDaniel said about the training. I was very surprised that CNAs were only required to take, I think mine was a 6-week course, 4 hours in the classroom and 2 hours of clinicals. But then I also was shocked to see that some other states were much less, like 2 weeks of training. But even after, 4 weeks in a classroom, you're in a classroom, but you don't have the hands-on, and you don't do the hands-on really until the very end. And so I didn't feel all that prepared by the time I went out there, but I learned. But yeah, I think that's something to look at even more.
Charlotte, are you still on the line?
Yes.
Yes. Since it doesn't sound like this was a General Assembly report, could you provide me with a copy of the report that you all are talking about the curriculum, so I can distribute it to the work group? Because if it's not a General Assembly report, I'm not sure exactly where it's going to be housed online.
Sure. And what it was a revision of the curriculum.
Right.
Yeah, so they took and, revised the curriculum, and the final curriculum is on the board's website now.
Right.
But I certainly can find notes. They are on Town Hall in our various board meetings, but I certainly can get those, compile them, and send them to you. You can see, how, the evolution of how things changed and why they changed.
Sure, that would be,
yeah.
I think that would be an interesting read. And like I said,
sure.
If it had been a General Assembly report, I wouldn't have asked because I know where those are all.
No, that's fine.
But I wasn't sure about that one.
Yeah. And just if anybody's wondering how many CNAs there are in the state, there's 51,652 as of the 30th of June.
Charlotte, can you repeat that, please? I missed it.
Yeah, 51,652.
Thank you.
In
This
relation
is
to LPNs, it's 28,000 LPNs.
Mm-hmm.
This is Senator Jen Higgins. Would it be a good time to interject? I know that our time is starting to run short. I didn't know how much longer or how many more slides you guys have. Do you have a while left? I kind of wanted to save my thoughts till the end.
Oh, no, go ahead, Senator Higgins. We're towards the end there.
Okay, that's what I thought. I had 1 to 4 on my schedule for everything, which I appreciate everyone sticking around. I know it's been a long 3 hours, so but I've been listening and taking notes, and I appreciate everyone's comments and insight. And since the last discussion point was just about the report to the General Assembly, I didn't see anything, and it slid past me. It was my first session this past year, so it was overwhelming. But I did not see anything. So, and I would have absolutely made note of anything that had to do with CNA or nursing certification. On that note as well, so I'm an adult geriatric primary care nurse practitioner, and I know that for nurse practitioners, at least, we changed our certification so that instead of being adult nurse practitioner and geriatric nurse practitioner, we combined it because we didn't have enough people that were wanting to go into geriatrics, and so much of our adult care involves older adults that I don't know if it was a Virginia Board of Nursing decision or that was kind of before my time, but of really being involved. But I think that was a really smart and a really good decision. So now all of us that are certified nurse practitioners are required that are going to be adult nurse practitioners are required to have a geriatric curriculum component so that we have an AGNP certification. And I don't know if that's, sounds like you guys just finished up this new hours requirement with the CNAs and LPNs, but adding that to a curriculum, I think has been wonderful for the nurse practitioner, job. So I would support something like that. And I just want to go back a little bit from the beginning. You guys have covered a lot of information today, and I know that today was talking about staffing and recruitment and retention and some educational components. So I want to thank everyone who's been here, especially the Dignity for the Aged people. I hear your passion. I live in that world too. That's where I grew up as a nurse practitioner, was long-term care, grandparents and facilities, all those things as well. So I hear your passion. I want you guys to know that, and I need you to be patient because, we have pushed hard in the General Assembly to get back up there to discuss a lot of things that's going on with Virginia with the COVID crisis. And we are just now getting a date for special session, which will be August 18th. Nursing home reform will not be the main thing to be discussed. In my world, yes, it would be the first thing that would be discussed. It will probably most likely be January, February, which I think was talked about earlier. But you are right, Sam, and that, people are paying attention now. Everything that has gone on, our nursing home disasters, and I hear all of you and all of your frustrations. A lot of us hear you guys. So it's not forgotten. I think those people have a voice now. People are paying attention. So I just need you guys to be a little bit patient. I too want nursing homes to be better yesterday or tomorrow, but we will get there. I think this work group is an important piece of it. I need input from everyone. I want to listen to what everyone's opinions are. My opinion was staffing ratios last January. It was turned into this work study. So I think we can build on that. I like the education piece. I've got kids in high school and college, and I think you can't go wrong with including a little bit of that component with volunteer hours. We can certainly, look into that. I don't think that's the only solution. I've seen some wonderful special needs people that have worked in long-term care. I think that, the blind and deaf piece, please include special needs people in that group because I think it's such a wonderful fit. Kind of like in my perfect world, we have all the daycares and the nursing homes together. So those two groups of people can feed off of each other, but special needs people as well. I think they're just a truly accepting group of people that I have just seen beautiful relationships with in long-term care. Veterans community, I'm a Navy veteran myself, and I was also a Navy wife for 20 years. So I think that is a untapped resource as well. There's a lot of transition assistance with veterans. And yes, we did pass the certification to make it easier for Navy spouses to I guess have their certifications be valid in the state that they have orders for. So I'm interested to see what our veteran representatives bring to this meeting next time, especially here in Hampton Roads, tons of veterans out there. The certification equivalency for nursing homes, I think that's also something to look into. Retention and recruitment is going to have a price tag. I think that the General Assembly is going to have to recognize that. You know, this was a budget year this past year, so we passed a very large budget that isn't particularly feasible. It's one reason we're going back to special session in August, because we have to tweak that and do some amendments to address some of the COVID crisis needs. But, you know, I think that the media has done a good job of highlighting a lot of things that happen in our nursing homes. So I think we will be willing to pay that price tag, or at least I hope so. So I'm not so much afraid that there's a cost, because there will be a cost if it's things like this, the loan repayment program, you know, recruitment bonuses, pay raises, facility improvements. There's a lot of things that I think we can do better in long-term care, but there will be a cost. So yeah, I think that the things we talked about, the exploring educational, you know, debt forgiveness, loan repayment, those are exciting things to think about for just incentives. You know, I think about why I got into long-term care. You know, I don't know if you can plant that seed in people. I've brought my kids into nursing homes a lot, and I'm not sure any of them say they want to grow up and be a geriatric nurse practitioner, but you can't go wrong with that. But I think it takes a special kind of person. I can tell you why I have left different facilities, and it was that administration was challenging, the pay wasn't good, and the working conditions weren't good. I was overworked and underpaid. So that's always in the back of my mind too when we talk about these things. It's a difficult subject, but I think this is a great group, a lot of insight from a lot of different places. So I'm listening, I am taking notes, and the one phone call I had with the governor a couple months ago, I talked to him specifically about long-term care, and I said, hey, I'm your geriatric nurse practitioner who's in the General Assembly. We're going to fix long-term care. We're going to at least improve it in Virginia. So he knows that that's my priority. It's not a partisan issue at all. And I think that we can come up with some good solutions. So thank you again for all of your participation. And I ask for just your continued patience, because we will get there, and we will get there next session. So thanks for inviting me and letting me listen.
All right. Thank you, Senator Kiggins. Well, we are approaching 10 till 4 right now. Hang on a second. I got to get my computer working again. All right. So for the next steps, Dr. Pratt and I will circle back with Veterans Services, deaf and hard of hearing, blind and vision impaired, to have them wrap up the curriculum piece for us. And also for the Veteran Services component, we'll circle back with Mr. Barnes about the specific programs that are there to help transition folks out of the military into civilian service, and specifically discussion about if there are any particular gaps that are there in the present programs, so that we may, as a recommendation, put forth filling those gaps in. If there are any other new programs that he feels might be of value to this conversation, especially those that may have been modeled in other states. In terms of the roadmap, it would be the wrap up of the education bit, the 2 bits that I just talked about right there, and then moving to the financing, the healthcare financing discussion. So as a reminder, sorry, I'm going to jump back a bunch of slides. This is what we have on there now. I know, having spoken with April Payne earlier in July, that there are some existing financial incentive programs that they have been kicking around, and I think it would be something to bring to everyone's attention, just what's out there presently, what's in the works, what needs support potentially from this work group, to see them go through, so that there is more money out there to pay CNAs, LPNs, RNs, the entirety of the clinical workforce, the salary that they are owed for the hard work that they do. We're also going to have a component about the payer mix and the reimbursement rates. It's going to be partially a sort of educational FYI, this is what the state of the payer mix and reimbursement rates are right now piece, but it's also going to be a discussion about ways that those rates can be potentially increased so that there is, again, more money available to be able to pay folks the salaries that they should be paid for the hard work that they do. So I think just based on the amount of material that we've gotten through today, between 1 and 4, that's probably going to take up the entire block. I will let you know that I've already talked to the staff here at the building, and there is a room already booked and set aside for us for that meeting. That will be August 4th. It'll also be from 1 to 4. It'll again be here, it'll be a hybrid, it'll be here at the Perimeter Center. Different boardroom though, will be down the hall, around the corner down the hall in boardroom 4. There will still be a virtual component for those who would like to participate virtually. It'll be through WebEx again, so just as a reminder, August 4th, 1 p.m., same bat time, same bat channel. It will be a hybrid meeting, and after this meeting, Dr. Pratt and I will get together, and since, hang on a second, I got to pull my calendar up so I can look at the dates and times. Hang on. Okay, so August 4th is 2 weeks from tomorrow. Dr. Pratt and I will meet after this meeting, and we will get a preliminary agenda distributed to you all by close of business tomorrow so that you all have that, and get that not only distributed to you all but also put out on the website, the OLC website, and also Regulatory Town Hall as well. Okay. And as I mentioned, there were some additional comments that were received from the public after the 1 p.m. cutoff yesterday, so I will be sending those out tomorrow as well as part of that same email. So you'll get the agenda and you'll get the written comments that came in after the 1 p.m. cutoff. And then in terms of the presentation itself, since there are pieces that we need, excuse me, there are pieces that we will need from other members of the workforce. So pieces from Veteran Services, deaf, hard of hearing, blind, vision impaired, et cetera. That obviously will not be able to be sent out tomorrow, but looking at the calendar, I would say I'll have that sent out to you all Wednesday the 29th. That way, Dr. Pratt and I can communicate everything we need to those respective agencies, and that gives them a week to get everything back to us to put it together and get it sent out to you a week and a day later.
I have a question for you.
Mm-hmm.
You said that you're going to continue to pass out the comments.
Yeah.
And I know some of the people are from our organization who were sending in the comments.
Right.
So my question to you is, what are we going to do with those? Are they going to be answered? Because that's why they're asking the questions. And so how are we going to handle that?
As I mentioned earlier, as a general practice, when folks are sending in written comments to work groups and stuff like that, they usually do not receive individual comments or individual responses, excuse me, unless they are including additional information in there that's beyond what the work group is about. So there was one that had the allegations about substandard care, for example. So for that commenter, I sent her back the standard, thank you for your comments, it will be distributed to the work group, et cetera. And also, because you've brought up allegations of substandard care, we are going to treat this as a complaint, and we will make sure that you get an individualized response to that part that's not about the work group activities.
So let me interject. Let me interrupt myself. So what can you say to the people, because it's better to come from you. I told them to write questions, and I told them they were allowed to do that, but from your perspective, what is the best way for them to ask a question so that it doesn't fall into a personal thing?
Right.
Do you know what I'm saying?
I think I know what you're saying.
Like, for
if
example,
I don't answer it correctly, I do.
If they have a question about, well, like many of them do, what do I do? There's not enough people to take care of my loved one here. She's dying. What do I do?
Right.
You know.
Hang on a second.
Somebody else saying it?
Yeah, I got to mute her line. Hang on a second. Okay, well.
Yeah, the last thing I want to happen is for me to encourage them to write questions and them to feel as helpless as they did before they asked the question.
So in terms of the individualized responses to them, I mean, if what they are writing in about is a specific concern that is happening right now, so the allegation of substandard care, like the mother has an infection right now, that is something that the Office of Licensure and Certification can, like we have a complaint process set up for that. If it is a more general,
well, for example,
I guess I don't understand
the
question,
Senate
sorry.
bill initially, when it was introduced, it was about ratios. And so, of course, that's, even though I've been corrected and I understand this is about the workforce, okay, a lot of people, if they're going to ask questions, it's going to be about ratios. It's going to be about the workforce as pertains to them because they are the ones experiencing it. Are you going to say you need to talk to licensure? Or do you see what I'm saying? Are we ever going to answer those kinds of questions?
As to whether or not staffing ratios is going to be a mandatory thing in Virginia, yes. I, as both the policy analyst for the office and as a member of the, I cannot promise them anything in terms of, oh yes, you will see this, or oh no, you'll definitely won't see. I can't make that. I don't have I can't make those sorts of policy decisions. That's not something that I'm empowered to do, and it's for the work group to come to.
Right. But what I'm saying is, okay, that's good. But if we have more and more people come forward from the public who say this is an issue, do you not feel like this work group would present that forward to the General Assembly as an issue that you have learned in this work group?
Well, I can't tell you the exact words that I'm going to use in the draft.
No, I know that.
I mean, Scott can certainly speak to this as well. Nursing staffing ratio bills have come up at multiple General Assemblies for many years.
Yes, I know.
It's not just been Senator Kiggins. I mean, she's new, so it was the first go around.
Exactly.
You know, it's been Delegate Watts. There's been others. So I haven't even begun to put anything in terms of a draft down, but in terms of like the historical information that's included in the write-up to the work group write-up, the legislative history of what brought us to this point is going to be in there. So that would be a component of it, is like, this has been tried. You know, there's been this session, this session, this session, this session, this session, that this has been brought up. It was brought up again, it was as the introduced bill, you know, it was brought up again in the 2020 session, and as a result of input from the various stakeholders, that staffing ratio bill became the bill that we find before us today, which is the mandate for this work group. And the purpose of the work group is broader than just staffing ratios. It's increasing the availability of the workforce.
Right, I understand that, but I guess...
I don't know why I was going to catch you.
I guess what I'm saying is, if I'm going to encourage people, and there are 800 of them, to come forward and be responsible citizens and say, hey, we need to hear from you. I want to make sure that while I'm encouraging them, it's not falling on deaf ears, and that this work group will embrace the concerns of these citizens and possibly put it forward. That's all I'm saying is if the people are going to come forward, I don't want them to say, I don't want to say, yeah, go ahead and do it, but nothing's going to happen.
Right.
I want you to embrace what they have to say.
Yes, the concerns that they bring to the work group, like I said, when we, specifically these that we're talking about, because they are nursing staffing ratio specific for the most part, like when we have that subject on the agenda, those comments, like the volume of comments we have received to date, they will be a part of the discussion, that we've received X number of comments, this many in favor, this many against, to the extent that there is a specific recommendation in them, here's what they say. I mean, and like I said, I cannot promise anyone, either as a work group member or as a policy analyst or any, like I don't have that authority to promise anyone that any specific recommendation is going to show up. But it's on the roadmap to be something to be discussed. And I mean, in terms of the comments that we receive, I mean, I'm trying to think of what would be a good example. The one that comes to mind is kind of contentious, but like, for example, the abortion regulations, as you can probably imagine, we get a ton of comments about abortion regulations, which we no longer regulate abortion facilities. But when we did, we would get a lot of comments about that. The volume was unimaginable. And when we got those in, I mean, that's basically how we had to triage the comments that we had coming in. These are the folks who are supportive of the general idea of the regs, don't have a position, are against it. And for those piles, then if there were specific suggestions, we would pull out those specific suggestions and be like, because, I mean, if someone just writes in and says, I'm opposed to abortion facility regulation, it's good to know, but like that's about as far as I can take it. Whereas if someone writes in and says, I'm opposed for the following reasons, and I want to see these specific changes made to the regulations, for example, that had a little bit more utility because there was a response that could be given to it, for example. So, I mean, that's generally how we triage comments, any comments that we get, whether it's for meetings like work groups like this, if it's regulations, it's grouping them together and then pulling out the specific ones in terms of.
I want to convey to the Dignity membership a way that they can get a voice heard, because that's what our organization is about. And I want to make it conducive to what you're trying to do too, so it's not just stuff. So thank you for saying that, because hopefully they'll listen to it and they'll understand. Thank you.
I mean, we value public participation. I mean, if we didn't, we wouldn't. I mean, we have not only the oral public comment period, we also have the written, because some people may not be able to get it all out in 2 minutes, for example. So we think it's valuable to have both pieces there. And just because you file a written doesn't mean you're not allowed to also speak to the board, as was the case with Ms. Schroeder. We managed to make it happen.
Well, and understand too, I know I've displayed a lot of passion today. I happen to be Italian-Irish, so it just comes with the package. But I do care, and our group does want to work with you. So we want to know what the rules are, what the parameters are, so that we can help you help us.
Well, I have kept you all 5 minutes past. I do apologize, but if there's no other questions? No? All right. Well, thank you so much for your time. I will send out the calendar invite. You will get the agenda tomorrow, along with the other comments that have rolled in after 1 p.m. yesterday. And then, as I said, the presentation will go out to you all on Wednesday, the 29th, so that we have enough time to work with the various agencies to get their pieces together and stitch it all up.
Thank you.
Super.
Thank you.
Thank you.
Thank you.